Welcome to our webinar on chemical peels. Today is a 1-hour overview of chemical peels. This webinar is intended for anyone that is currently working with chemical peels that might need some reminding on how they work, how to perform them, which acids to choose, and how to manage the patient and their treatment plan throughout the process. If you're very experienced in doing chemical peels, there might be some information that you will already know, but this webinar might introduce you to a new way of building treatment plans or using a new ingredient that you might not have used before. The topic of chemical peels is a very relevant and important topic that must be covered in great detail so that a thorough understanding can be gained on how these treatments can be utilized effectively and safely on a wide variety of skin conditions and skin types. Today's webinar is a little over 1 hour and definitely not enough time to cover the basics of chemical peels and all the other info we need. This is a little intro to the topic of chemical peels to ensure that you understand the topic in detail. This webinar is aimed at providing some of the latest information and data on chemical peels as a whole and is intended for someone who is currently already performing chemical peels. For those of you who don't know us, my name is Lisa van Zyl, and together with my partner Riolette, we own Skin Skills. We aim to educate everyone working in medical aesthetics by providing free webinars, short courses, and masterclasses on various topics related to the skin and skin conditions. Today we will cover the following topics: patient consultation, determining the correct candidates for peels, acids, pH, and their application in different skin types, preconditioning before procedures, and post-treatment care. The importance of the skin as part of our immune defense cannot be overestimated. We must never forget that every time we inflict a controlled wound into the skin, we are triggering an immune response from the skin. The severity of this immune response will determine the level of injury and the amount of inflammation that is stimulated. In certain skin types, this inflammatory response can be exceptionally beneficial in stimulating the skin's healing mechanisms. But in other skin types, it can trigger the melanocyte into producing too much melanin as a defense mechanism. How do we know if we are triggering too much inflammation on a specific skin type? The answer lies in our experience with peels, our consultation with the patient, the level of preconditioning that is done before the peel is done, and also the way the skin is handled in the days following the procedure. The classification of peels are done according to their depth of penetration. Before choosing an acid or peel for your treatment plan, it is very important to understand where the problem lies that you are trying to treat. Let's take a look at a few examples of how you would go about selecting a peel for a specific skin condition. If you had a patient that has acne, depending on the grade, it usually involves a superficial part of the epidermis, but in the cases of grade 4 and 5 acne, it involves part of the dermis. This means it'll take significantly longer to treat, as we cannot penetrate the papillary dermis on the first session. It is also very dangerous to treat a patient with inflammatory acne with a chemical peel too soon, as they might experience post-inflammatory hyperpigmentation due to the fact that there is an active immune response in the skin. We must precondition the skin very carefully before starting with a chemical peel. The cumulative effect of milder peels will eventually improve the skin condition and, along with a medical grade home care regimen, will restore the skin's health, preventing future breakouts. Hyperpigmentation disorders can also extend into the dermis, and to avoid disappointment from the patient's side, we must ensure that we identify the depth of damage before we select a treatment plan for the patient. They must understand that we cannot simply peel the problem away. We have to ensure consistent renewal of hyperpigmented epidermal cells over a period of months, with a combination of clinic procedures and resurfacing actives at home to achieve good results. Because the melanocyte is triggered when there is an injury to the basal keratinocytes, or excess inflammation in the superficial layers of the skin, or delayed healing of the barrier, We must take a conservative approach in treating hyperpigmentation in darker skin types, and particularly in patients that suffer from melasma or post-inflammatory hyperpigmentation. Aging requires various depths of penetration throughout the patient's treatment plan. If there is fine lines and mild hyperpigmentation, superficial peels done at specific intervals, spaced closer together, will do the job along with the good actives that they are using in their home care regimen. If there is deeper wrinkles, a medium depth penetration to the papillary dermis might be needed. Improved firmness can be achieved with cumulative peels done over time, but if you want a serious improvement in laxity, a deeper chemical peel is necessary, and this often extends into the deeper papillary dermis or immediate reticular dermis. This also requires significant downtime, and not all patients will be good candidates for these type of peels. Screening patients involves more than just looking at their Fitzpatrick skin type, and this is often where some of the biggest problems occur. A guideline to screening patients involves the following points. Analyze the patient's motivation. Why does the patient want to have a chemical peel? What is her preconceived ideas? Does she think she can peel the problem away? Is her skin disorder a chronic problem that is not curable with a chemical peel? And is there a better alternative like microneedling that will suit the patient better? If she cannot tolerate some downtime, or if she has a lifestyle that predisposes her to significant UV radiation, she might not be the best candidate for a peel. Analyze the patient's expectations. Does she think one peel will be sufficient? Is she aware that she will need a course of treatments before she will see results? And does she realize that her results will only be as good as her compliance with her home care regimen? Does she realize that there are no guarantees, and how long does she have to commit to a treatment plan? Does she expect to peel significantly, but the peel she is indicated for will produce no visible peeling? These are all some of the questions that we need to answer during the consultation phase. Glycolic versus Fitzpatrick skin type. When will you choose to do which assessment? Glycolic is really only effective in measuring the stage of aging in lighter European skins. This is very helpful for lighter Fitzpatrick skin types, but skin type classification utilizing the Fitzpatrick method is more suitable for darker skin types, as it will indicate the risk for post-inflammatory hyperpigmentation better than the Glycolic scale. The tolerance level of the skin must be assessed by utilizing an active ingredient in the first session of her treatment or in one of her home care products. If the patient shows very little tolerance to that ingredient, their preconditioning period must be extended until their level of tolerance has improved. We must always assess the health of the patient. Anything that affects the immune system must be considered as a factor in determining whether the patient is a good candidate for a peel or not. We must pay specific attention to whether the patient has an autoimmune disease or any other disease that affects their healing rate. This includes diabetes and whether they are a smoker, as this will also affect their ability to heal post-procedure. We must also assess whether the patient has been on a course or multiple courses of antibiotics recently, as this will reduce their immune system's ability to respond to injury. This will also affect the gut microbiome as well as the skin microbiome negatively. We must assess what medication they are on and how this affects their skin. There are various types of chronic medication such as antihistamines, antibiotics, and medication prescribed for diabetics, which are photosensitizing, and care should be taken during the preconditioning and post-care phases. If the patient is on hormonal contraceptives or currently undergoing fertility treatment, this will also increase her risk for the procedure. If the patient has a tendency to jump from clinic to clinic in the past because nothing has ever worked for her, make sure that she understands that unless she commits to a protocol and has the patience to see it through, you will not be able to treat her successfully. The ideal candidate for a peel is a patient that understands the following. They will need to go through a period of preconditioning that involves the use of specific home care regimens in the weeks leading up to the procedure in order to reduce inflammation and strengthen the skin's barrier function. They must have excellent sun protection habits by the time they have the procedure. They must have a realistic expectation of what can and can't be achieved, and they must be willing to give the treatment plan the time it needs to alter a damaged and unhealthy skin into a healthy skin. They must be willing to invest in their home care regimen, as what they do on their skin every day can be even more important than the procedure itself. They must also invest in the necessary post-care products, as these are specifically developed to restore the skin's barrier once it has been temporarily damaged. Our epidermis plays a very important role in protecting us against all external elements. However, it can become altered in a negative way and contribute to the formation of disorders and diseases if it is not properly looked after. Reasons why we might consider procedures to restore the health of the epidermis include the following. A hyperkeratinized skin. Chemical peels have various different mechanisms of action. One of them is to dissolve the desmosome bonds between keratinocytes so that the cellular renewal of the skin is improved. This also stimulates the removal of damaged keratinocytes. With repeated superficial peels, you can greatly reduce the signs of hyperkeratinization, which include blackheads, flaky skin, and uneven compacted stratum corneum. Keep in mind that the cause of hyperpigmentation is a lack of moisture in the skin, and your home care regimen should aim to restore hydration to improve poor desquamation in the long run. When referring to aged skin, we must remember that part of the skin we are trying to target. Aging concerns such as wrinkles, lines, laxity, and a rough, environmentally damaged skin is more prevalent in lighter Fitzpatrick skin types. Clinical signs of aging tends to look different in different Fitzpatrick skin types. Where your lighter European skins have a decreased resistance to UV radiation, they see the appearance of wrinkles, lines, and laxity much sooner than your darker Fitzpatrick skin types, 4 and up. 4 and up tend to see the appearance of hyperpigmented lesions sooner and more frequently than lighter Fitzpatrick skin types, with the exception of freckles, of course. The treatment of aging involves a holistic approach, and chemical peels alone will not reverse all signs of aging, but they do a tremendous job of improving the skin's texture, color, and overall health. In lighter Fitzpatrick skin types, there is a general guideline of slowly building tolerance until we can apply a chemical peel that reaches the basal layer of the epidermis or the papillary layer, where we can induce a significant amount of collagen remodeling. However, a medium depth peel will only be suitable once a patient has shown tolerance to a superficial peel. A thorough understanding of the clinical endpoints when performing peels is necessary if we want to treat aging in patients with chemical peels successfully. Hyperpigmented skin. Chemical peels can be extremely useful in the treatment of hyperpigmentation disorders. The acidic pH of most peels digest existing melanin deposits. The mild controlled injury stimulates the healing mechanisms of the skin, and damaged melanin-laden keratinocytes can gradually be removed with repeated chemical peels. There are 3 things that we must consider before attempting to do a chemical peel on a hyperpigmented skin. The Fitzpatrick skin type. The treatment itself can stimulate excess melanin production in darker skin types, which means that they are limited in terms of the strength and the types of acids we can use. Usually a combined approach works best, such as superficial peels, microneedling, and active home care regimens. The second factor is the type of hyperpigmentation. If the underlying cause of the hyperpigmentation is inflammatory, chemical peels should be done with caution. This includes melasma and post-inflammatory hyperpigmentation. The third factor is the cause of the hyperpigmentation. If the cause is systemic, such as the result of hormonal fluctuations or systemic disease, the cause must be addressed before we can successfully treat hyperpigmentation with chemical peels. Remind your client that hyperpigmentation is a chronic disorder and cannot be cured with a chemical peel. It requires a long-term maintenance protocol to ensure sustainability of the results. Peels, such as retinol peels, are great for maintaining results once they are achieved because they digest melanin deposits in the skin and over time will thicken the epidermis enough to reduce the susceptibility of the melanocytes to damage. Make sure that acne is addressed before you start peels on the skin. Certain acids will penetrate unevenly in oily skin. Salicylic acid is a prime example of this. Longer preconditioning is required and we must ensure that we get the inflammation under control before we start doing peels. For this, we must reduce sebum levels, reduce the hyperkeratolytic plug, and reduce P. acne formation and proliferation within the pilosebaceous follicle so that we can improve the skin's natural defense mechanisms against bacteria. The skin's natural defense mechanisms is our acid mantle and our microbiome, and this will only be intact if we use the correct home care regimens. If there is pustular acne, there is an infection and immune response which must be resolved before we can apply a chemical peel to the skin. For this, ingredients such as benzoyl peroxide work well, but this should only be used for 2 to 6 weeks maximum to reduce bacteria, because if we use it for longer, we can cause antibiotic resistance. Take note that this dries and sensitizes the skin and will require a period of stopping the product in the weeks before the procedure is done. Home care should involve mild alpha hydroxy acids or retinoids to restore the barrier function, and evenly hydrated skin is crucial in controlling the penetration of actives during the procedure. A chemical peel's overall effect will be determined mostly by the type of acid and the combination of other actives that are used. Some other factors that determine the outcome of a peel include the pH. The lower the pH, the stronger the peel. There is often confusion about this fact and comparing it to the concentration of the acid that is used. For instance, we could have 2 glycolic acid peels. They both have a 30% concentration. The one has a pH of 3.7 and the other a pH of 1.7. Which one do you think will be strongest? However, if we have 2 glycolic acid peels that both have a pH of 1.7, but one has a 20% concentration and the other has a 50% concentration, the 50% will naturally be stronger and penetrate deeper. The second factor is the pKa value. Each acid has a particular pKa value. The closer the pH to the pKa value of the particular acid, the more salt versus acid it contains. Therefore, the closer the pH and the pKa value, the milder the peel. So if a glycolic acid, which has a pKa value of 3.8, is buffered to a pH of 3, the chemical peel will be milder. But if the glycolic acid has a pH of 1.5, the peel is stronger and there is more acid than salt available. The medium in which the acid is suspended is another important factor to consider. Generally, gel mediums penetrate slower and more controlled, while fluid-liquid mediums have a rapid absorption rate. In the case of TCA, this process works slightly differently. As TCA is a non-neutralizing peel, it coagulates proteins in the skin. Its strength is determined by the volume applied, in other words, the amount of layers applied. The rate at which it absorbs is determined by the concentration of the acid. The pH will also play a huge role, as the higher the pH, the less protein is coagulated. This means that you get the same level of injury with a 15% as with a 25%. You would just need to apply more layers or increase the volume. This is also what makes TCA so tricky to work with. If you don't wait long enough between applications, you might miss your clinical endpoint, and once you've applied your next layer, it cannot be neutralized and it will continue to penetrate until all protein has been coagulated. The strength of the acid is determined by the pKa value. This table demonstrates the strength of acids from weakest to strongest. This explains why a 5% TCA is way stronger than a 5% lactic acid. We know that talking about preconditioning and not doing peels too soon can seem like we're taking the fun out of treating the skin and improving skin health. But once a patient has been thoroughly preconditioned, we can become extremely creative with our approach to peels. The other benefit of preconditioning period is that certain ingredients in their home care regimen will improve the skin condition you are hoping to treat. Using specific ingredients in the 2 to 6 weeks of preconditioning will have tremendous benefits. Here is an example of what you should focus on when preconditioning for a procedure. Restoring skin barrier function involves the following aspects. Firstly, we must restore the pH of the skin by ensuring that the patient is using a pH balanced cleanser and toner. We must restore epidermal lipids and natural moisturizing factors because this will reduce the amount of transepidermal water loss we experience. We can do this by increasing the amount of hydrating ingredients in the patient's home care regimen. Re-establish a healthy desquamation cycle. By improving the skin's ability to desquamate, we should increase the amount of hydrating ingredients and exfoliating actives that the patient is using in her home care regimen. If there is significant irritation, sensitivity, and dryness, we must provide immediate relief to give the skin a fake barrier until we can restore the natural barrier function. This might involve prescribing some occlusive moisturizers to the patient for a short period of time until the barrier function has resumed. If the skin has a chronic disease such as acne, particularly where there is infection present, we must provide a solution that can be used in the long run to maintain skin barrier function. Use a mild, gentle cleanser and toner to maintain the acid mantle. Ensure that the moisturizer that you recommend contains adequate hydrating benefits, anti-inflammatory ingredients, and antioxidants to repair and prevent free radical damage. Ingredients such as CBD, niacinamide, EGCG, which is the active ingredient in green tea extract, and polyhydroxy acids, which are a more sensitive version of alpha hydroxy acids, are great and offer multifunctional benefits to restore the natural defense mechanisms of the skin. This barrier restoration regimen can be used in the 2 to 6 weeks prior to a procedure to restore the skin's natural defense mechanisms and to reduce the risks associated with that procedure. For severely impacted barriers that can barely tolerate active ingredients in a home care regimen, we must first re-establish the impacted defense system. This means restoring epidermal lipids and natural moisturizing factors. We love ingredients such as EGCG, that is one of the most anti-inflammatory topicals that we can apply to a very compromised barrier. It has the added benefit of also being a tyrosinase inhibitor, and it also reduces sebum production and will balance the sebum secretions in a oily skin. CBD has shown excellent results in restoring that initial barrier function of the skin. Niacinamide is a powerful antioxidant, anti-inflammatory, tyrosinase inhibitor, and balances sebaceous secretions, so very useful for all skin types. Sodium hyaluronate is an excellent hydrating ingredient, and panthenoic acid will restore that lost barrier that we sometimes find the patient struggles with post-procedure. Once the barrier is less sensitized, which can take anything from a few days to 2 weeks, we can start introducing the actives that will prepare our skin for treatment. We will refer to 3 types of ingredients: alpha hydroxy acids and polyhydroxy acids, retinoids, tyrosinase inhibitors, and antioxidants that double up as tyrosinase inhibitors. If you'll be using alpha hydroxy acids in your procedures, then there are some benefits to using alpha hydroxy acids in the home care regimen in the weeks leading up to the procedure. It reduces the thickness of the stratum corneum for even penetration of acids, increases the skin's tolerance to acidic ingredients, reduces corneocyte adhesion, and stimulates hydration. If the patient cannot tolerate alpha hydroxy acids, then polyhydroxy acids may be used instead, as they produce the same benefits with less irritation because of their larger molecular size and their slower penetration. It's crucial to introduce some form of exfoliating active in the home care regimen leading up to the procedure. This ensures an even stratum corneum and equal hydration in the skin, which will result in an even penetration of acids during the procedure. Retinoids have so many benefits for preconditioning. Besides being great for all skin types, they will also improve the wound healing process after the procedure has been done. For acne-prone skins, they reduce sebum and the follicular plug, therefore improving acne lesions. For aging skin, they thicken the epidermis and improve the nutrient and oxygen supply to the epidermal-dermal junction. This is because they improve angiogenesis and blood supply to the epidermis. They encourage the production of extracellular matrix components and will therefore kickstart the collagen induction process before we do our procedures. They are also very powerful tyrosinase inhibitors and will therefore start the process of digesting excess melanin deposits to reduce the risk of post-inflammatory hyperpigmentation. The choice of retinoid will be dependent on the brand that you stock in your clinic, as well as the patient's skin condition and skin type. Keep in mind that retinoids must be stopped 3 days pre and post-procedure. Free radical generation must always be addressed, as reactive oxygen species will increase the degradation of collagen and increase melanogenesis. Consider your choice of antioxidant carefully. L-ascorbic acid supports collagen induction and is therefore great for aging skin. Sodium ascorbyl phosphate reduces sebum production and is therefore good for acne-prone skins. And tetrahexyl ascorbate is a powerful skin lightener and will therefore be good for hyperpigmentation disorders. We will be discussing more on this topic during our cosmetic chemistry webinar. But if this highlights the importance to you of choosing your ingredients before you do your procedure carefully. Using a product with alpha-arbutin kojic acid, or tranexamic acid for that matter, will be important during the preconditioning phase for people who already suffer from post-inflammatory hyperpigmentation, as it will desensitize the melanocyte to reduce the post-procedure risk. Niacinamide reduces sebum, reduces melanin, improves inflammation, so it is ideal as a preconditioning agent. There are many other examples of great actives with multifunctional benefits that we will discuss in our cosmetic chemistry webinar. These are examples of acids that are used when we do highly superficial peels. We always recommend starting with these to increase the tolerance of the skin before moving on to medium depth or deeper peels. Superficial to medium depth peels are capable of treating more challenging concerns such as freckles, melasma, fine lines, large pores, and uneven skin texture. Care should be taken with darker Fitzpatrick skin types, as they might be contraindicated for these procedures and need a slower, more conservative approach. Glycolic acid thins the stratum corneum and thickens the stratum granulosum. The stratum granulosum is where the lipid composition of our keratinocyte changes, and this will improve epidermal lipids. It also reduces transepidermal water loss in the long run. Effects are highly dependent on the pH, and a lower pH with low concentration is the most effective yet safest option. Due to the fact that glycolic acid is a water-soluble peel with a small molecular size, It penetrates rapidly but slightly unevenly, and therefore caution should be taken when using high concentrations as it can penetrate deeper than intended. The irritation associated with glycolic acid results in it not being the best option for a first-time peel. Lactic or mandelic acid might be a more comfortable choice. One of the key problems occurring with glycolic acid is that it is often inadequately neutralized, which can increase penetration over time. Glycolic acid is not the ideal choice for improving laxity or moderate to severe textural abnormalities. Glycolic acid is best when utilized in low pH and lower concentrations, more frequently, and in a minimum of 4 sessions. Clinical endpoints of glycolic acid is redness in areas, and high concentrations should produce diffuse redness at the very most. Frosting should never occur with glycolic acid, as this acid is not ideal for penetration to the papillary dermis due to the fact that it penetrates unevenly and can cause scarring when it penetrates deeper than intended. Lactic acid is structurally almost identical to glycolic acid. It has a slightly larger molecule and penetrates a little bit slower. It also has excellent hydrating properties, which makes it one of the best choices to do on a patient as a first-time in-office peel procedure. It shows better tolerance than glycolic acid, and therefore it can be used instead of glycolic acid on darker skins, higher risk skin types, or skins with more sensitivity and redness. Mandelic acid penetrates more uniformly through the epidermal layers than glycolic acid, making it a better choice for oily skins and skins with barrier dysfunction. It reduces cutaneous sebum production and has antibacterial effects, and is therefore an excellent choice for people with acne or oily skins. It is a great tyrosinase inhibitor and is absolutely perfect for darker skin types that have both oily skin and post-inflammatory hyperpigmentation. Its large molecular structure means that it penetrates very slowly and controlled way, so that it's an ideal choice for a first-time peel option. It's also a good option for preconditioning the skin for stronger acids and procedures to follow. Salicylic acid essentially melts the cells when they come into contact with keratinocytes in the epidermis. This is called acantholysis. Salicylic acid is a lipophilic acid and is thus systemically absorbed. This means there's a higher incidence than other acids to produce allergic reactions, so care should be taken. Cytotoxic effects are very rare, but you should avoid applying concentrations higher than 30% due to the small risk of cytotoxicity. Salicylic acid penetrates very rapidly into the skin, which is one of the reasons why it can often create post-inflammatory hyperpigmentation in darker skins, because by the time you neutralize it, it has already penetrated too far. It should ideally not be left on the skin for longer than 3 to 5 minutes. Frosting is not a clinical endpoint of salicylic acid, and as its penetration is slightly uneven, you should avoid frosting on the skin. This means that in certain areas where there is more sebum, it can penetrate deeper than intended, and therefore there is also an additional risk of post-inflammatory hyperpigmentation in darker skins with oily skin. This is particularly risky with patients that have acne-prone skins, and ironically, salicylic acid is used most often to treat acne. Mild to diffuse redness should be the maximum clinical endpoint. It is advisable to precondition with a milder peel such as mandelic acid first until good skin tolerance has been achieved. Although this acid can be a little bit risky to use, it's extremely effective when used in the right way on a well preconditioned skin. Resorcinol's mechanism of action is much like that associated with phenol. It produces both acantholysis as well as coagulation of protein. Although this coagulation is associated with keratinocytes, care should be taken when using this on darker skins because it can penetrate too deeply, too rapidly. There are not as many systemic side effects associated with Resorcinol as with phenol, so it can be a safer alternative to phenol or a more conservative option for higher risk patients. Resorcinol's benefits are varied. It is absolutely excellent for the treatment of melasma or hyperpigmentation disorders, as well as aging disorders and mild acne scarring due to its wonderful collagen remodeling benefits. Unlike alpha hydroxy acids, a TCA peel is a self-neutralizing peel. It penetrates rapidly, and as it coagulates proteins in the epidermis, it neutralizes itself. The higher the concentration of the acid, the quicker the penetration, and this means higher concentrations should therefore be reserved for people with a lot of experience working with TCA. The volume applied will determine the depth of penetration. This means that you can get the same depth of penetration with a lower concentration acid if you apply more layers than with a higher concentration. One of the most frequently experienced problems occurring with TCA is that the penetration goes deeper than intended. This is usually due to inaccurate preconditioning of the skin, leaving the room while the peel is on and not observing the clinical endpoints, and applying the next layer of the peel too quickly without waiting at least 5 minutes. We must respect the period of relative resistance. Do not return to a previous area of application before the time period has passed, because this means you can achieve deeper penetration than intended. TCA is not a peel that should be performed if you are in a hurry. Take your time and watch your application technique. The application technique is important because too much product can run and cause deeper penetration in certain areas, leading to post-inflammatory hyperpigmentation. Using gauze is abrasive and will influence the rate of penetration significantly. A thorough understanding of clinical endpoints is required when doing TCA peels. Diffuse redness is usually achieved with a first layer, indicating deeper epidermal penetration. Once scattered or cloudy frosting occurs, we know it has penetrated the basal layer, and a solid frost with a pink background indicates upper dermal penetration. This should only be reserved for experienced physicians in lighter Fitzpatrick skin types. Once you see a solid frost with no pink background, it indicates a penetration to the immediate reticular dermis, and this is reserved for extreme cases in lighter Fitzpatrick skin types only. Pyruvic acid is an alpha keto acid with similar lipophilic and keratolytic properties as salicylic acid. It is excellent for the treatment of acne vulgaris, but only in Fitzpatrick skin types 1 to 3, and should only be used on a thoroughly preconditioned skin, as the risk for deep penetration and post-inflammatory hyperpigmentation is big. It is extremely effective at treating severe aging concerns and improving scarring and laxity in the skin, but it must be neutralized thoroughly. There is significantly more downtime than salicylic acid, and it should therefore only be done after a patient has already been preconditioned with other procedures of chemical peels, and once they have shown tolerance to chemical peels such as salicylic acid, they should be considered as a good candidate for a pyruvic acid peel. If you've been working with chemical peels for some time, chances are you've had an unforeseen event or complication arise either during a procedure or after, despite your best intentions at avoiding it. Avoiding variables can be very difficult, and even with the best preconditioning and prepping of the patient's skin, you might still have a patient that responds unpredictably to a procedure. This is where your understanding of clinical endpoints come into play. Start by understanding where the problem lies that you are treating and how deep you can penetrate with your chosen acid. Remember that doing a medium depth or deep peel on the first visit is not possible, as the patient must build a tolerance to the acid first. Explain to the patient that the cumulative effect of many milder peels will provide similar results to 1 or 2 more aggressive peels with less downtime and less risk. If you're doing an entry-level peel with alpha hydroxy acids, Make sure that the clinical endpoints that you observe in the skin match up with the intended depth of penetration. Understand that if an alpha or beta hydroxy acid is not thoroughly neutralized, they will continue to penetrate deeper and deeper the longer they are kept on the skin. Water to neutralize these peels is not enough. Make sure your distributor has provided you with a proper neutralizing solution, and if you're in doubt, neutralize twice. Many patients develop complications in the hours following a peel because it wasn't neutralized properly. Understand that these type of complications is highly possible in darker Fitzpatrick skin types, simply because it's harder to see or observe your clinical endpoints than it is in lighter skins. We should therefore take our patients' feedback on their comfort levels during the treatment very seriously. We should also make sure to follow the exposure times that the distributor gives us. Always time your peel. Never guess for how long the peel has been left on. All it takes is 30 seconds for a peel to penetrate a fraction too deeply than intended to cause lifelong scarring and hyperpigmentation disorders for the patient. Macrophages, which are cells present in the dermis that play a role in our immune functions, also play a role during the formation of dermal melasma and post-inflammatory hyperpigmentation. When there's an injury to the skin or a severe chronic inflammatory trigger, the melanocyte will respond by producing large amounts of melanosomes. If the melanocyte dendrites become too heavy, they will dump melanosomes into the papillary dermis. It is here that they are often engulfed by macrophages, which morph into melanophages. This can happen during the procedure as well. The picture on your screen is a great example of what post-inflammatory hyperpigmentation looks like, and this often occurs as a result of a procedure that is done on the patient that has a disrupted barrier. The melanocyte's role in immune responses should not be underestimated. It is statistically significant that both the melanocyte and the Langerhans cell is situated in the epidermis. This means they play equally important roles in our immune defenses. It gives them ample opportunity to encounter pathogens which might harm the skin and body. The fact that the melanocyte is situated here, is dendritic, and responds to external stimuli should be an important factor to consider in the treatment of hyperpigmentation disorders such as post-inflammatory hyperpigmentation. Please remember that melasma is highly sensitive to inflammation, hormonal fluctuations, and heat. If a patient has melasma, their genetic tendency is to react unfavorably to acute inflammation. Therefore, the treatment approach should aim to reduce inflammation, improve skin barrier function, and our approach initially should be very conservative to see how the skin responds first. This is particularly relevant if the patient has a known hormonal disorder, autoimmune disease such as lupus, or any other source of chronic systemic inflammation. Post-inflammatory hyperpigmentation occurs in different ways as a result of the normal wound healing that the skin experiences when we have a chemical peel. Post-inflammatory hyperpigmentation can also happen due to the abuse of harmful topical ingredients such as hydroquinone that is used for too long in too high concentrations. This can cause a debilitating skin disease called exogenous achromatosis, which can often masquerade as melasma or post-inflammatory hyperpigmentation, and due to the fact that this skin disorder is not treatable with chemical peels, can often create disappointment for the patient when they don't achieve a good result. Darker Fitzpatrick skins are more prone to post-inflammatory hyperpigmentation. Studies show that it is the degree of pigment in the skin rather than the patient's ethnicity that contributes to the development of post-inflammatory hyperpigmentation. Another factor is that darker skins have an abnormally pathophysiological response to cutaneous injury, which results in the stimulation of the melanocyte. Allergies, hormonal fluctuations, autoimmune diseases, and any chronic medication that causes photosensitivity will all contribute to the formation of post-inflammatory hyperpigmentation. There's also a common misconception that when we do a course of peels, we can sometimes stimulate underlying pigment to surface. This is an inaccurate way of describing the process of post-inflammatory hyperpigmentation. Yes, it is true that hyperpigmentation can sometimes get worse before it gets better, but this is a risky way of treating the skin, as there are many variables that can cause the patient to retain the post-inflammatory hyperpigmentation that is stimulated by a chemical peel. A conservative approach is required to observe the patient's healing after the procedure has been done, to observe their compliance with home care products post-procedure, and to observe their compliance with sun protection following their procedures. Make sure that if you are anticipating some mild post-inflammatory hyperpigmentation during a chemical peel course, that you are prepared to target it with effective home care products. Don't keep performing peels if the post-inflammatory hyperpigmentation gets worse, as this is a clear warning sign that you've gone too far. Wound healing is a sequence of complex and well-orchestrated events. Although the precise mechanism of wound healing is not fully understood, three interrelated phases, inflammation, migration, and remodeling, require coordinated activity for successful wound healing, which is a progressive series of events facilitated by various cells like platelets, leukocytes, fibroblasts, and keratinocytes. Platelets facilitate homeostasis and the release of growth factors. Then, leukocytes participate in the inflammatory process. Fibroblasts and keratinocytes have a critical role in wound healing by enhancing reepithelialization and the remodeling of the extracellular matrix. One of the key reasons we love retinoids for preconditioning is the fact that it enhances the skin's ability to reepithelialize. The skin's ability to proliferate keratinocytes following a procedure is significantly faster when retinoids have been used in the weeks leading up to the procedure. The choice of retinoid is dependent on the skin's tolerance, the state of the barrier, and the depth of the chemical peel that will be performed. This indicates the type of retinoids that should be used when preparing the skin for specific chemical peels. If you are doing an alpha or beta hydroxy acid peel, retinol derivatives should be sufficient in preconditioning the skin. If, however, you are doing a medium depth or combined peel, pure retinol would perhaps be the best option, as it improves angiogenesis quickly and improves blood flow. It also enhances keratinization significantly faster, which will improve the epithelialization of the skin following the procedure. If you are performing a TCA, Pyruvic, or phenol peel, you should consider using retinoic acid or tretinoin to precondition the patient before they have the procedure done. The hydrolipidic film or acid mantle is made up of sebaceous and sudoriferous secretions. This creates a slightly acidic environment on our skin that allows for the colony of commensal bacteria and fungi to exist. This combination of healthy flora will ultimately protect us against harmful microorganisms that might damage the skin. When we inflict a wound into the skin, there is a decrease in the skin's pH. This is a natural occurrence, and the speed at which the acid mantle repairs itself will determine the risk for post-procedure infection, which leads to inflammation and can subsequently trigger severe post-inflammatory hyperpigmentation. If the pH is too alkaline before we perform a peel on the skin, this means our natural microbiome is disrupted and our wound healing rate is slower, which is the opposite of what we want if we are trying to do procedures. It is therefore crucial to re-establish a healthy acid mantle and microbiome prior to the start of a cosmetic procedure, regardless of the depth, but especially in medium depth or deeper peels. As mentioned in some of our previous trainings, we truly love micellar cleansers as they cleanse and tone in one, and they don't alter the pH in a negative way. Some micellar cleansers contain alpha-hydroxy acids or anti-inflammatory ingredients, which may also help with the relevant skin condition you are treating. It's important that you reduce the amount of harmful cleansers that the patient uses in the weeks leading up to a procedure to reduce the risk of their acid mantle becoming too alkaline and therefore impacting their wound healing rate. The skin microbiome is the most important protective mechanism we have. Removing the microbiome with a procedure makes us more prone to chronic inflammation and infection after the procedure has been done. It is therefore very important to ensure we are applying either an occlusive or semi-occlusive ointment in the days following the procedure, depending on the depth that the procedure has penetrated. It can take a few days for the skin to restore the stratum corneum, so we must make sure that we provide a barrier to prevent the entry of harmful microorganisms and pathogens into the skin. Should the skin start oozing or crusting post-procedure, a broad-spectrum antibiotic ointment such as Bactroban can be applied. If the skin develops abnormal swelling and itching, a corticosteroid can be prescribed. If the peel has penetrated the stratum granulosum, we must ensure that the epidermal lipids are replaced until the stratum granulosum has repaired itself. In some cases where we want shedding of the skin to occur, we must be careful to apply too much post-procedure product that is too occlusive, as this can cause the following problems. It can reduce the amount of flaking experienced if that is the ideal outcome of the treatment. In deeper peels, it can cause premature removal of epidermal layers as the moisture softens the damaged skin layers and causes them to peel prematurely. Follow the instructions of the manufacturer post-procedure. Focus on ingredients rather than texture of the product and superficial peels. The anti-inflammatory benefits of a post-procedure ointment will reduce the likelihood of post-inflammatory hyperpigmentation. In deeper peels where there is significant drying of the epidermis, a semi-occlusive ointment is necessary, but it shouldn't be applied more frequently than necessary. Sunscreen, sunscreen, and more sunscreen. There are some impressive clinical studies that show the incredible efficacy of using a hypochlorous acid solution post-procedure for the following reasons. All microorganisms are killed within seconds of application. It has superior anti-inflammatory effects and will reduce the risk of post-inflammatory hyperpigmentation. It improves migration of the keratinocytes and fibroblasts to encourage faster wound healing. This, therefore, is a great option to use immediately post-procedure and to provide the patient with a home care product that she can use in the days following the procedure. Let's take a look at a case study to apply what we have learned. In this patient, we would consider the following before choosing the correct procedure for her. She clearly has a compromised barrier, excess keratinization, and excess sebum, which makes her high risk for a chemical peel. She therefore needs thorough preconditioning with polyhydroxy acids, which are more gentle than alpha-hydroxy acids, and hydrating barrier-restoring ingredients that reduces inflammation in the skin. Due to its tolerability, mandelic acid might be a good acid to start with before a gesner or salicylic acid is used. Mild peels done more frequently would be best because she clearly has a problem with her acid mantle, which could impact her wound healing mechanisms negatively. Make sure that if you are treating someone that has an existing hyperpigmentation disorder, that they are thoroughly preconditioned with tyrosinase inhibitors. This will reduce the hyperactivity of the melanocyte and reduce the risk of worsening the hyperpigmentation disorder with the chemical peel or procedure that you are doing. If you have a patient with pustular acne, this means there's already excess inflammation and infection in the skin. Extreme caution should be taken when doing chemical peels on these skin types, as technically they are contraindicated until you can get the inflammation and the infection under control, either with medical prescription-based approaches such as benzoyl peroxide or non-medical alternatives such as niacinamide. This should be done in the weeks leading up to the procedure to reduce as much of the infection and inflammation to reduce the risk of post-inflammatory hyperpigmentation following the procedure. Thank you so much for joining us. Don't forget to subscribe to our YouTube channel and select the little grey button, which will update you every time we upload another free video. Make sure to check out our other free webinars and follow us on social media for more free resources. We offer some amazing online short courses and masterclasses, so be sure to visit our website for more details.